This machine is going to actually be done in dim light, which is closest to night vision when the pupil size is maximum. And there is a measurement where we know how much more it's going beyond the normal range, where the normal, pupil size taken average is 8.5 millimeter, that's total ablation zone. Then that's increased to 9.0, seeing it expanding more than the usual ring size that we have at 6 in the air.
Yeah, I mean, we can increase the pupil, on the people who we think is necessary, we can increase the pupil size to be wider than the pupil. I mean, that's essentially what we're trying to do. Although you guys got to be careful, and you're so smart on the internet research. If you go to like Medline and stuff like this, like that kind of stuff, ask Craig, because Craig's a doctor. He's learning some primary surgery. So Craig, if you look at all the articles that have been published in the medical literature, how tight is the correlation between pupil size and symptomatology at night? Is it a strong correlation or a weak correlation?
I'd say strong.
No. That's why Craig needs to do a fellowship. It's a very weak correlation. You hear about this all the time. If you look at actual studies, it's a very, very weak correlation. In other words, there are many, many people out there with normal pupil size who have a lot of symptoms at night. And there are people, I have patients with huge pupils, like 9 million people, no symptoms at all. And when you do the actual studies, then you better Medline this and look. The studies show such a weak correlation that if you go to ASCRS and there are these national experts that they're talking, all of whom I know and all of whom know me, they'll say, this is really just to relieve the fear and anxiety of the customer, but you and I know pupil size is really not that important. You'll hear this at ASCRS. We went to ASCRS. People are saying this.
I read about that also, yeah. The correlation is not
It's a very bad correlation. And the reason it's out there is it just makes sense to people intuitively. But if you actually crunch the numbers, the correlation is not there. Now, we don't need more pupil size. We will match pupil size, and we will increase the zone. And on your guys' things, if we're doing the workup today, you should pull both those charts, by the way. Then just circle increase zone. If they want to increase zone, we'll increase the zone. Sometimes we have to increase the zone. In your case, it's a little bit like we don't actually need to increase the zone. So if you want the zone increased and we have the tissue for it, we'll increase the zone. Okay? What's the next question?
And with Visage laser, it allows you to go down with the spot basically to 0.6 millimeters, right? So
like the size of the spot? Yeah.
So it automatically does that based on that wavefront?
Yes, it'll automatically, it's called VSS, okay? It's variable spot size, okay? So essentially, if you look at the laser shooting, and you can stay and watch the procedure if you want today, you'll see that it's going all over the cornea in different spots, and the size of the spot's different. Sometimes it's small, sometimes it's big. The reason Visage did this is actually very smart. If they have, there's other lasers that are of a small spot always. And even though you might think intuitively that's better because it's more precise or whatever, it's actually bad. The reason is, it's going to take you longer to do an area that's all the same prescription than it should. You're going to have to basically take a pencil when you should in that area be using a brush. You see what I'm saying? So the Visage thing, sometimes it'll use a brush when the whole area is the same treatment, and some areas uses a spot. It's the best of both worlds. By using a brush sometimes, it decreases treatment time, and the length of treatment time has actually been statistically, in studies that were published, inversely correlated